네, 소개 감사합니다. 안녕하세요. 저는 영국 런던에서 있는 University College London UCL에서 Postdoc Research Fellow로 일하고 있는 구민정입니다. 세미나를 들어가기 전에 먼저 이런 자리를 마련해 주신 브릭팀과 그리고 오늘 시간 내서 참석하신 분들께 감사의 인사를 드립니다. 첫 인사말은 이렇게 한국어로 마치고 이제 세미나는 영어로 진행하겠습니다. So, as I just said, thank you so much for having me here and inviting me to talk. My area of research is public health and epidemiology, focusing on the early diagnosis of cancer. And I know this is a topic that isn't commonly featured as part of the BRIC seminar series. So it's really great to be here, and I'm really looking forward to some of the discussions that we may have after the talk. So I'm here to talk about our recently published study in the Lancet Oncology on the presenting symptoms of cancer and stage at diagnosis. This piece of research was done as part of my PhD, and that was funded by the UK's Department of Health Policy Research Unit in cancer screening and early diagnosis. But before I go on to that, um, I do have a small disclaimer or perhaps conflict of interest to mention. So a lot of what I'm going to be talking about today um, in terms of the policy context, in terms of the research landscape, is focused on the United Kingdom. And in fact, the data that I'm going to be talking about, from which our findings arose, is based on England, so one of the four UK nations. However, in spite of this, given the nature of the topic, I think our findings have relevance not only for the remainder of the UK, but also more broadly speaking for symptomatic early diagnosis. So with that in mind, I wanted to first begin with some of the motivations of why we were looking into early diagnosis, some of the motivations behind the field and the perspectives there. So there are a lot of ways in which we can improve cancer outcomes. In fact, there's a whole continuum of cancer control measures that we can take. So this goes from primary prevention, including tobacco use, diet and physical activity, environmental exposures to asbestos and other substances, right through to end-of-life care and palliative care. What I'm interested in is early symptomatic diagnosis, and this fits into secondary prevention alongside population screening. So here I need to make a big distinction between those two. So cancer screening is done amongst the asymptomatic population and is considered early detection of cancer, whereas the field I'm talking about, the research I'm talking about, is the early diagnosis of individuals who are already presenting with symptoms. So if we want to catch cancer earlier, I guess some may say, well, why focus on early diagnosis of individuals who are already showing symptoms? Why not focus our efforts on screening or primary prevention? Well, first of all, obviously, it's important to say that early diagnosis of screening is one of the several arms of cancer control, so hopefully everything is equally important. But also, there are two major statistics that support early symptomatic diagnosis. So first of all, only around 40% of cancer cases are attributable to known risk factors. So in other words, even if we spent all our resources and time and energy on primary prevention, that would be insufficient to help the remaining 60% of individuals diagnosed with cancer. That wouldn't prevent those. Secondly, and perhaps more importantly, the vast majority, so 90 to 95% of all cancer cases, are diagnosed following symptomatic presentation. And what this means is that focusing on cancer screening, whilst innovation and new technology is certainly useful and necessary in that field, it's always going to be insufficient because there will always be a large proportion of individuals who present following symptom onset. And bearing in mind that both of these studies are based on the English population, and England is a country, the UK is a country where the health system is free at point of care, point of use, and the cancer screening programs for breast cancer, cervical cancer, and colorectal cancer have been ongoing for many years nationally. So in spite of that, this is what we're seeing. The other reasons why early diagnosis is important, if I may go into further detail, are manifold. So early diagnosis is associated, as you may expect, with better clinical outcomes, including stage at diagnosis and as measured via survival. And it is absolutely important for patient experience of the treatment of cancer and their subsequent care. Um, as a sort of secondary thought, early diagnosis is often more cost effective for the health system. And again, from the UK perspective, where we have a single payer for the entire health system, this can become very important. Again, kind of focusing on the UK context, early diagnosis has been a strategic priority in the UK for around 20 years or so, and that's partly because of some research that came out indicating that cancer survival in the UK was poorer relative to other comparable countries, and this included jurisdictions in Australia and Canada, and also Scandinavia, so Denmark, Sweden, and Norway. So Denmark didn't do very well either, so it was the Denmark and the UK who were consistently shown to have relative poorer cancer survival, but this was partly attributed to late diagnosis. And so since then, there really has been a big push in terms of the policy, in terms of the research for early diagnosis. So as part of this big push, there have been several types of early diagnosis activities that have been run in the UK. But before I explain that, I've just got a very simplified view of the diagnostic pathway of cancer in the UK for a typical individual here. So I'll just talk through that first so you have a sense of the health system and the structures we're talking about. So first of all, an individual develops symptoms. These symptoms could be what we call alarm symptoms. So alarm symptoms are typically those that are strongly associated with cancer. So they have a high predictive value of cancer. And this includes things like rectal bleeding for colorectal cancer, breast lump for breast cancer, um, hematuria or blood in the urine for bladder cancer, etc. So hallmark signs of cancer that raise alarm in both the individual and the healthcare professional. So symptoms can be alarm symptoms or non-alarm symptoms. So often cancer symptoms are very vague and non-specific, such as fatigue, weight loss, things like that. So the individual develops symptoms and decides to seek help for these symptoms to their general practitioner or GP, which is the primary care base. And this is the first point of call that the patient can go to apart from A&E or emergency services here in the UK. And at this point, the GP may decide to undertake further investigations and manage the symptoms there, or else, if they suspect cancer, they are obliged to refer these individuals on for further investigations and management in a secondary care facility, so at a hospital. Once these individuals are referred, then that is what often leads to the diagnosis and therefore treatment of cancer. So in terms of reducing the time from symptom onset right through to diagnosis, what can we do? Well, first of all, the patient interval, so the time from symptom onset through to when the individual seeks help for these symptoms, it has been shown to be considerably long, particularly for symptoms that are perhaps non-specific or symptoms that are otherwise thought to be unconcerning by the patient. And so there has been a massive effort to increase the awareness amongst the general population of possible symptoms of cancer through massive population level symptom awareness campaigns. And these have been ongoing since around 2011 and have been robustly evaluated with a lot of data that comes out of this. Once that individual has presented, as I mentioned, the GP is then in charge of that individual and refers them on. Now, we know that cancer is still a rare disease amongst the population, and so often that time from that individual presenting to their general practitioner to when they are referred for suspected cancer can take quite a long time. So this again has been around for a very long time, but for cancer we have a fast track pathway that GPs can use for individuals who present with symptoms, particular symptoms that may be suspicious of cancer. So this is called the 2-week wait pathway because the idea is that the individual will have their secondary care appointment at a hospital within 2 weeks of being referred. And just to tell you that otherwise, if they were referred via routine measures, an appointment can take up to almost months to be scheduled in. So this is quite a big deal and goes a long way towards expediting the diagnosis of cancer. And I know I said this would be a very UK-focused talk, but actually there is global interest in early symptomatic diagnosis. So the WHO produced a report on the early diagnosis of cancer in 2017. And earlier this year, they produced a report on cancer, again highlighting the importance of both asymptomatic cancer screening and early symptomatic diagnosis. What I thought was quite interesting is they highlight the importance of early symptomatic diagnosis as being perhaps a lower hanging fruit for cancer control plans, particularly in resource poor settings where the health system infrastructure or the availability of technology may prevent the introduction of a screening program that is robust. And to the right here, I've just put a few examples of various symptom awareness campaigns, and these are, as you can see, these range from high-income countries, but also lower and middle-income countries. This is Ghana and Malaysia. So there are all these ongoing activities that are trying to expedite the diagnosis of cancer among individuals who have symptoms. But how do we know which symptoms these interventions should be targeting? So up until now, there's been very little evidence that is used to select these symptoms. As I mentioned, the 2-week wait pathway does use some evidence. This is primarily based on the predictive value of a symptom for cancer. So how many individuals who present with a particular symptom go on to be diagnosed with cancer? But the slight problem there is we don't know what stage of cancer that individual may turn out to have. And there's been some concern that some symptoms, things like weight loss and coughing up blood, may actually represent advanced disease. And if we focus our efforts on speeding up the diagnosis of these individuals who have advanced disease, yes, this is still important for patient outcomes, but there is doubt on whether this would make much difference to their clinical outcomes. So this is important to examine, but associations between individual symptoms and stage prior to our study had previously not been very well defined at population level, particularly those types of studies looking across different cancer types. So our main research question was how the presenting symptoms of cancer may be associated with stage at diagnosis. Okay, so I want to keep this section a little bit quite brief, talking about the data and the methods, but I did want to describe the study population to you so you know who we were looking at and the types of statistical analysis that we undertook. So we used data from the English National Cancer Diagnosis. Audit, the NCDA 2014, and this is a very unique source of information because it combined data from both cancer registration and from primary care records. So first of all, NCRAS, so the National Cancer Registration and Analysis Service, identified individuals who had been diagnosed with cancer in 2014. And that means we've got cancer registry level information on cancer sites. So we've got the ICD codes for that, and also, crucially for this piece of research, stage a diagnosis. Um, the GPs that I talked about earlier, participating GPs, so not everyone, but a large proportion of GPs provided information on the diagnostic pathway of each individual based on the information contained in their primary care records. So they went back and manually looked for information on various aspects, and this included information on that patient's presenting symptoms and other variables and patient characteristics that will come in important for our analysis later, so things like socioeconomic status. For our study, we focused on around 8,000 patients who were diagnosed with one of 12 solid tumors. So we were looking at stage of diagnosis, and so we first of all focused on patients who were aged 25 years or older with any cancer other than hematological malignancies or brain and CNS tumors. And that's due to the poor correlation between stage of diagnosis and prognosis for those individuals. We excluded patients with cancer sites that had poor stage completeness, so cancer sites associated with high levels of missing data on stage were excluded, high being um, less than 85%. And so the 8,000 strong study population that we examined ultimately represents around 80% of incident cases in England in terms of the cancer site case mix. In terms of the symptoms, we looked at 20 symptoms. Information was actually available on for 81 symptoms that were noted at first presentation before the individual was diagnosed with cancer. But we looked at the 19 most common symptoms and then collapsed the remaining symptoms into any other symptoms category. And this meant that patients could have one symptom or any combination of multiple symptoms. This is going to become important in the next bit when I talk about analysis. So when we were examining symptoms and stage, we first looked at the proportion of patients who were diagnosed with stage 4 disease, defining advanced stage as stage 4, and conducted logistic regression examining the odds of stage 4 versus 1 to 3. So ideally, we would have liked to look at every single symptom combination and the proportion or odds of stage 4, but instead of that, because that's going to be impossible unless you have an infinite sample, we looked at the presence or absence of a symptom when it was seen alone, so as, when a symptom was seen by itself as a single symptom, and separately when the presence or absence of a symptom when seen with other symptoms. So in other words, we undertook two versions of this descriptive analysis and two versions of the logistic regression analysis. Okay, so moving on to the results and discussion, I'll go through some of our main findings and highlight the interesting bits and move on to some of the implications. Okay, so as I mentioned, we looked at proportion of patients with stage 1 to 3 versus 4, and that is what is seen here. So if I just explain the figure to you in a bit of detail, these are the 20 symptoms of interest that we looked at. And for each symptom, you can see two bars. The first one on the left indicates when that symptom was seen alone, and the column on the right, the bar on the right, indicates when that symptom was seen with other symptoms. So patients who had abnormal mole plus other symptoms, for example. And these symptoms are ordered in proportion of stage 4 versus stage 1 to 3, as you can see. And there is some variation in the proportion of advanced disease associated with each of these symptoms. So symptoms that are typically localized, so abnormal mole, breast lump, postmenopausal bleeding, rectal bleeding, these are largely considered alarm symptoms of cancer. And you can see that large proportions of these individuals were diagnosed with stage 1 to 3, although you can also see that there are some individuals who were diagnosed with stage 4. On the other end, you have neck lump. That's often a sign of lymph node involvement, so unsurprising to see it associated with stage 4, and other symptoms such as chest pain, back pain, and hemoptysis. But the overall picture that was very surprising when we first came across this was that large proportions of patients are diagnosed at non-advanced stages. So disregarding neck lump for a second, for the remaining 19 symptoms, a minimum of 38% of individuals were diagnosed with non-advanced disease. And that's considerable given that some of the symptoms that we looked at included things like chest pain, back pain, hemoptysis, dyspnea, so difficulty breathing, etc. So just to highlight an example and illustrate this further, I've picked up on weight loss, again, typically associated with late stage, advanced stage cancer when an individual presents with this symptom. But what we found was that 62% of individuals who had this symptom alone and went on to be diagnosed with cancer had stage 1 to 3 cancer. And among individuals who had weight loss and other symptoms, and this could be any number of other symptoms, 1 in 2 individuals did not have stage 4 and they had stage 1 to 3. So quite surprising results, bearing in mind that these are crude or observed findings where we haven't adjusted for anything. So, well, that is the next step. We did adjust for patient factors. This is the output of the logistic regression model that I mentioned, where we looked at the association between our 20 symptoms and stage at diagnosis, adjusting for an individual's sex, age group, ethnicity, IMD quintile, and also their subsequently diagnosed cancer site. Just to mention that including cancer diagnosis in the model means that we were able to essentially adjust for the case mix of cancers that we had in our study population. And so it does strengthen the external validity of our findings for other settings, other countries, etc., where the incidence of cancer may differ. And again, just to explain the figure in a bit more detail, here we have our 20 symptoms again. This time we have the odds of being associated with stage 4. So the higher you are means the more strongly you are associated with stage 4. And again, you can see neck lump, chest pain, back pain, hemoptysis being on the higher end, and abnormal mole, breast lump, postmenopausal bleeding, etc., being on the lower end. But really, the key message behind this figure is when you compare the blue set of dots with the red set. So the blue set of odds ratios is where we've just included the symptoms, and the red set is when we've looked at symptoms and covariates, so these other patient factors. And you can see that while there is some attenuation, the rank order of symptom-specific odds of stage 4 does not change substantially. And that suggests that what we were discovering in terms of the descriptive analysis on the previous slide, the unadjusted crude findings, hold when we've adjusted for patient factors. And this was the case for symptoms seen alone. We also conducted the same logistic regression analysis, but for symptoms when they were seen with other symptoms, as I mentioned, and found comparable findings. And that is actually presented in the supplementary material because there wasn't much difference. Okay, so what does this mean? Well, the findings suggest that no presenting symptom is a very reliable indicator of stage at diagnosis. So there wasn't any particular symptom that was 99% or 100% associated with non-advanced disease. And On the other hand, there wasn't any symptom that was 100% associated with stage 4 disease. So what this suggests is that it's never too late to seek help for symptoms which may be caused by cancer, and it's never too late to investigate them from the from the healthcare professional's perspective. We also found there was little difference between when symptoms were seen alone versus when symptoms were seen with other symptoms. And what this suggests is that the nature rather than the number of symptoms is more important for stage of diagnosis. So our findings can be used to inform public health and healthcare system policies to promote early diagnosis. So in terms of the awareness campaigns or fast track pathways that are all based on and predicated on the types of symptoms that are selected for prioritization, this could help policymakers prioritize which symptoms to select. And that's it. So I'd obviously like to acknowledge my co-authors, so Dr. Ruth Swan, Dr. Sean McPhail, and Ms. Lucy Ellis-Brooks were all based at the National Cancer Registration and Analysis Service at Public Health England. Dr. Gary Abel is based at the University of Exeter. Professor Greg Rubin is based at Newcastle University, and Professor Yoris Laratzopoulos, my boss, leads the Epidemiology of Cancer and Healthcare Outcomes Group, ECHO Research Group, at UCL. And finally, to acknowledge and thank my postdoc funding, which comes from Cancer Research UK. All right, thank you for listening, and I look forward to our discussions.